I'd like to invite Dr. Rishi to start with this presentation.
Good morning, everyone. Thank you, Dr. Saloni. Respected members on the dais, my talk on glaucoma and the current trends, how to navigate the pathways. I have no financial disclosure. Why to assess first for a patient who's coming to our OPD? So we have to first determine whether there is a presence of glaucoma, or to exclude any alternate diagnosis, understand mechanism of damage to guide management, and to identify the right form of treatment. So what to assess? So a patient comes to you, first go for the history, then examination, and then the investigations related. So in the history, most glaucomas, including the angle closure ones, are asymptomatic until advanced. Therefore, it's important that you ask the history of the patient. The medical and social factors will also affect the treatment. Plus, the patient with the older age and having a positive family history of glaucoma will also decide how his eyes are going to end up. Also ask about the past ophthalmic history like medications, steroids, any trauma, any history of eye surgery. So visual symptoms of glaucoma, usually in angle closure and pigment dispersion, you can see that the patient will come up to you with a visual blurring and discomfort. Rest, usually people do not complain of any symptoms. There can be glare, there can be colored halos. A very important symptom is that the patients will complain that they have very poor light and dark adaptation, that they move from dark to brighter areas and or bright to dark areas. They have some difficulty. Plus, glaucoma patients have this thing, that is, they are not able to track high-speed objects. And especially if they are driving, then there can be crowding. So the factors affecting patients of suspected glaucoma, you have to ask about the respiratory, asthma, COPD that will limit the use of topical beta blockers. Then cardiovascular, any arrhythmia, systemic hypertension, migraine, blood loss. In endocrine, you should ask about the diabetes because it increases the prevalence of open angle, any existence of thyroid eye disease, any pituitary tumors. In CNS, if the patient is suffering from dementia, then it becomes really difficult to treat the patient. Then musculoskeletal, patient will have arthritis, so he'll have difficulty in putting the eye drops because his fingers will be very difficult to push that drop. Patients with urinogenital stones, that will limit our use of carbonic anhydrase inhibitors. Then any history of ocular trauma will lead to angle recession or lens dislocation. So the management will change. And for a steroid of any route of administration is always associated with ocular hypertension or open angle glaucoma. In such case, the treatment differs. We have to minimize the use of steroid. Then the prolonged use of glaucoma drops may increase the trap failure. Plus, a patient already on anticholinergics or TCA antidepressants, that can lead to angle closure. And a person already on systemic beta blockers and calcium channel blockers for hypertension will interact with his topical beta blockers. So how to examine the patient? You should have a good slit lamp with indirect lens, 90D preferably, or a direct ophthalmoscope. Then you should have an automated perimeter, a gonioscope, and a tonometer. Now, what are the factors which affect the IOP measurement? There is a circadian rhythm related to our IOP. Usually it peaks at around 4 to 6 a.m. and then troughs at around night. So that diurnal variation is around 3 to 6 millimeter of mercury. But in patients of glaucoma, the variation is more, and it can be more than 8 millimeter of mercury also. Then the thinner corneas, they artificially lower the intraocular pressure. Blood pressure, especially the systolic pressure, if high, can lead to higher IOP. And with each decade change after 40, there is a rise of 1 millimeter of mercury in the IOP. Plus, there are yoga head down positions, the postures which involve downing your head can further increase the IOP by 2 to 6 millimeter of mercury, and use of alcohol may decrease it. So the measurement errors with the GAT are that they can be artificially low if you do not put the proper fluorescent. It can be high if the patient is not comfortable, he's squeezing his eyelids, or you are putting a digital pressure on the globe if the patient is obese, breath holding. Other difficulties are like patient is already having a scar, a graft, corneal edema, astigmatism, nystagmus, small aperture, or any tremor. So in the entry segment, you will look for any episcleral blood vessels, any follicles. Entry chamber, look for pigments on the endothelium, KPs, and for the iris, look for any mid-dilated pupil poorly reacting or isolated zones of patchy atrophy, rubeosis, synechia, pseudoexfoliation, transillumination effect. These are the things you have to look. And on the lens, you can look for pseudoexfoliation material, lens thickness, the phacodonesis, and glaucoma flecken. Now coming to the gonioscopy, you have to detect this angle closure, whether it is occludable, or there are secondary glaucomas where the angles are open but they are blocked. Look for angle width. Now suitable illumination is required, which is low, good anesthesia, smallest slit possible, and with the highest magnification. Now set your slit lamp on the upper cornea of the gonio mirror, where you can see the inferior angle first. Don't put the light on the pupil, as it will artificially constrict the pupil. Then you can go and examine the nasal and the temporal side. Now if the scleral spur is visible, then record your findings. If it is not visible, then you can see for any indentation, and if the angle open, then it is like primary angle closure. And still, if you see that there is associated IOP rise, then it is angle closure suspect. Now in angle closure, you will see pass, then there will be pigmented patches over the trabecular meshwork, which is sign of iridotrabecular contact. Then there will be, in the abnormal open angles, there will be TM pigments. Then there will be new vessels, abnormal iris processes. Ciliary body, look for any angle recession, any cyclodialysis cleft. And in some cases, you can see the blood in the Schlemm's canal. So how to examine the optic nerve head and the retinal fiber layer? You have to see the disc size, the neuroretinal rim. And here, the importance is the size of the disc altogether. If a large disc is large, so it will have a larger cup disc ratio, but the rim will be having a good circumference. Therefore, it may not have any nerve fiber layer damage. So there is a chart where you can see that a small disc will have a mean cup disc ratio of 0.26. But in a disc of more than 2 millimeters, you can see that a mean cup disc ratio is 0.55. So both these are normal. Now, in a patient, when he comes to you, always draw the optic disc, the rim, the key vessels, any notches if you see, any shelving or any particular rim thinning of the rim in the clock hours, whether the Isent rule is followed or not, any visible defect if you have dilated the patient. Also note the vertical CD ratio. If it is possible to take a optic nerve photograph, then do take it and hand it over to the patient, so that when next time he comes to you, he has a recording and you can compare. Also note for any hemorrhage, bearing of circumlinear blood vessels, any bayoneting. And large discs have large CDR, even though NRR is normal, which we have talked about. So here you can see that in a moderate glaucomatous optic neuropathy, localized loss of both inferior and superior neuroretinal rim is there. And a classic inferior notch can be seen, where in the small arrows you can see. And NFL defect in both the superior and inferior arcuate will cause a visual field defect. In the advanced optic neuropathy, neuroretinal rim thinning is very large, and the cup extends to the disc rim. It's almost 0.9. Then there you can see circumlinear blood vessels bearing, bayoneting of the blood vessels, The peripapillary atrophy is also there. And in visual field examination, it defines the state of the optic nerve function and the visual impairment associated with it. Automated perimetry helps when glaucoma is suspected. So if a patient comes to you, you can order a automated perimetry, and the characteristic of that glaucomatous damage will be shown by the asymmetrical across horizontal midline. And it will be located in the mid periphery, around 5 to 25 degree of fixation. Then there will be clustered defects in the neighboring test points, and this defect correlates with the optic disc picture and the examination you have drawn. So the goal of treatment is the risk factor reduction, the IOP, and look for any angle control if angle is shallow, what all you can do, and treatment of the predisposing disease like diabetes, uveitis, and steroids. So the objective is to maintain a functional vision throughout the patient's lifetime with good quality of life. A slow disease in an elderly patient results in little progression, but a patient coming in a younger age and having a faster disease will lead to blindness. So our goals will be to deepen the angle, to give an iridotomy to reduce the pupillary block, and we can use lasers to do iridoplasty, and we can also do lens extraction early to reduce any pupillary block. Usually if lens swells more than 4.3, 4.4 millimeter, it's better to extract it in early stages. And in cases of malignant glaucoma, we have to go for vitreous surgery. So the target IOP, what is target IOP? In a treatment naive patient, record the IOP of the patient when he is coming to your OPD. And it is based on the pressure reduction required to slow down the disease progression. So we have 4 groups of glaucoma, where the first group is having a high risk of visual loss. That is definite optic neuropathy can be seen with visual fields loss. So we have to reduce the IOP by around 30%. That is like lower teens. And in group 2, where the glaucoma is having a moderate risk of visual loss, that is mild GON can be seen, early visual field loss, or in ocular hypertension with more than 30 millimeter of mercury pressure, then the reduction required is around 20%, that is mid-teens. And in a glaucoma suspect, you can see that there is suspicion around the disc, the fellow is having established optic neuropathy, the OST with suspicious disc, then you have to reduce further by 20%. And in group 4, where there is low risk or they are associated with having a family history, or PAC or PDS, fluid exfoliation, hemorrhage, then in such cases you have to, you may not start the treatment at once, and you have a close monitoring and see the progression. So we have laser treatments available, and in that we have laser trabeculoplasty, which actually burns the TM and opens the channels. While in cases of end stage, where there is usually the patient is PL denied, then we can reduce the inflow by doing a cyclophotocoagulation. In PACG, patient coming to you with pupillary block, do a laser PI. And in end stage, again, you can do cyclophotocoagulation. So in laser spots, you have to see that if you are using the power, then it should be around 300 to 1200 milliwatts. The spot size should be around 50 micron for argon and 75 for diode lasers. Duration should be 0.1 second. You can give 30 to 50 spots evenly spaced over the 180 degrees. So I will recommend that you give around half of the 360 degree at once. Don't give full 360 degree bunch on one sitting. It can cause temporary blurring, IOP spike, and some pass can be there, or it can also lead to chronic increase in IOP. It is effective, relatively non-invasive, preferable to surgical iridectomy. Cyclophotocoagulation reduces the production of aqueous by destroying the ciliary epithelium for cases where we have failed multiple filtering surgeries and we have to alleviate the pain of the neovascular glaucoma, the patient is having painful blind eye, and surgery is not possible. So we have drugs which are prostaglandin analogs. We are all accustomed with that: bimatoprost, latanoprost, travoprost, beta blockers. carbonic anhydrase inhibitors. There are new generation of drugs, ROCK inhibitors. So I'll not go into the details. Then we have surgeries, which are the traditional penetrating filtering surgery, trabeculectomy, and the non-penetrating surgeries. Then we have glaucoma drainage devices, the MF glaucoma wall bare welt. And the newer thing is to have a lens extraction, early lens extraction in cases of PSEG, and goniotomy and trabeculectomy for childhood glaucomas. And there is option of MIGS, which is micro-invasive glaucoma surgery, which was recently developed by Dr. Ahmed in 2008.